Hello, and welcome to Alzheimer's disease and dementia care training. My name is Pascale. I'll be your presenter for today. These are the modules that we'll be going over today. If you are administration, RNs, DON, any upper leadership staff, please stay to the entire presentation. If everyone else, please discontinue watching the slides following the first 4 modules. Module 1, Overview of Alzheimer's disease and related dementias. Here are some statistics about Alzheimer's disease according to the Alzheimer's Association. More than 5.8 million Americans currently are affected by Alzheimer's disease. Someone develops Alzheimer's disease every 65 seconds. Almost 2/3 of Americans with Alzheimer's disease are women. It's the 6th leading cause of death in the United States. 1 in 3 seniors, that's 1 in 3 of our residents here, will die from Alzheimer's disease or another form of dementia. It is the only disease in the top 10 causes of death that cannot be slowed or cured. Over $290 billion are spent annually caring for persons with dementias or other types of dementia. And over 16 million people in the United States are unpaid caregivers with over 18.5 billion hours of care. So it's said by year 2050, there could be over 16 million Americans diagnosed with Alzheimer's disease. And the cost of caring for those people would be estimated to be $1.1 trillion.
What is dementia? Dementia is the name for a group of symptoms that commonly include problems with memory, thinking, problem solving, language, and perception. In a person with dementia, these symptoms are bad enough to affect daily life. Dementia is not a disease in its own right, and it is not a natural part of aging. Rather, the symptoms of dementia are caused by different diseases that affect the brain, including Alzheimer's disease. Dementia is caused by a loss of nerve cells. It is a progressive condition, meaning that symptoms gradually get worse. This is because when a nerve cell dies, it cannot usually be replaced. As more and more cells die, the brain starts to shrink. This can sometimes be seen in a brain scan of someone with dementia. These scans show a slice through the middle of the brain from the front, like looking through the middle of a stick of rock. They show what happens to the brain of someone with Alzheimer's disease as their dementia progresses over several years. Note how the black areas become larger. This is because the brain tissue, the grey areas, continues to shrink or atrophy as nerve cells die off. Common symptoms of dementia include problems with day-to-day memory, concentrating, organising and planning, as well as difficulties with language and visual perception, and changes in mood. However, each person will experience dementia differently, and the symptoms depend on the areas of the brain that are affected. For example, if cells in the temporal lobes start to die, that person might have difficulties with their language. Nerve cell death in the occipital lobes can cause problems with vision. There is currently no cure for dementia, and many of the diseases that cause it are terminal.
Dementia is not a disease. It's a general term or umbrella term to describe a condition that affects memory and other mental abilities, severe enough that it impacts your daily living. Dementia is caused by actual physical changes to the brain. There are specific diseases that cause dementia. Among them is Alzheimer's disease, which accounts for 2/3 of all dementias. Typically, a loss of function in more than 2 areas of cognition will suggest dementia. Areas such as language, judgment, memory, spatial abilities, and/or visual abilities can all be impacted by dementia. Is dementia reversible? No. Dementia is a progressive condition which attacks the brain and gradually gets worse over time. As of today, it cannot be slowed or cured. Conditions that may mimic dementia symptoms but can be reversed depending on severity are listed here. Conditions such as brain tumors, depression, dehydration, anesthesia from surgery, infections such as UTI, which can cause some cognitive deficits. But once you resolve the UTI, the cognitive deficit should also resolve. Unlike dementias, which are listed here, such as Alzheimer's disease, Pick's disease, Parkinson's disease, vascular dementia, all these diseases cannot be reversed and are progressively getting worse over time. Another common diagnosis that can mimic dementia, and it's often confused as dementia, is delirium. Delirium is a sudden onset or start of confusion due to medical, social, or environmental conditions. Dementia, as we said, is a progressive and continuous loss of cognitive function that cannot be regained. Delirium typically occurs suddenly, as opposed to dementia, which may take a long time to develop symptoms. Individuals are unable to attend to tasks or stay focused, and symptoms may fluctuate throughout the day. You can see delirium occur typically following surgeries or when someone has an infection such as UTI. Most symptoms of delirium can be treated quickly and resolve back to normal or previous mental functioning. As we said, dementia cannot be resolved. Some increased risk factors for dementia are age, having a close relative with dementia, genetic mutations, which you can see plays a part with early onset dementias, multiple head contusions or injuries, typically seen with football players or boxers, or an unhealthy lifestyle such as smoking, poor diet or exercise, poor sleep, and excessive alcohol use. Areas of function impacted by dementia are seen here. They're divided into 3 categories, such as cognition, behavior, and emotion. So things such as memory, language are affected with dementia, as well as you can see some behavioral changes such as hallucinations, delusions, as well as emotional changes such as apathy or mood changes. The dementia can be broken down into stages. Here we have the 7 stages of dementia. The first stage of dementia, normal outward behavior. In this stage, people with dementias will usually go unnoticed because the only true change is occurring in the brain. Imaging scans, such as PET scans or CT scans, would be the only way to determine that you are currently in this first stage of dementia. As we move on to the later stages, you will start to begin to see the observable changes that occurs with people with dementia. Stage 2, very mild decline. In this stage, it is still very hard to see any symptoms because they are small. Changes such as forgetting your keys or forgetting a wallet or even forgetting the name of the store you want to go to. These are the changes that you would see in the stage 2. But people can still typically work and live independently. Most of the time, these changes can be interpreted as just normal aging decline. Stage 3, mild decline. This is where you start to notice more and more symptoms. People will start repeating questions or forgetting things they just read. They may start to rely on others to help them with their daily activities, such as taking medication or paying bills. If you can catch dementia at this stage, it would be wise to start putting your finances and medical power of attorney in order. Stage 4, the moderate decline. At this stage, you will start to forget details about oneself. They could forget the month or the season that we're in and can struggle with activities such as cooking or using the telephone. At this stage, safety concerns are becoming more important and should be seriously considered to prevent any injuries. Stage 5, a moderately severe decline. At this stage, short-term memory is severely impacted, and most people will start to rely only on their long-term memory, and that can be impacted as well. They can have personality changes or mood swings, and they will start to have more repetitive behavior, such as asking the same question over and over again. They will start to be disoriented more and will need increased help with their daily activities. Stage 6, a severe decline, mental decline. Here you would see changes such as increased personality and mood swings, and they can have delusions at this stage. They will need help with their basic daily living, such as bathing, dressing. If they can still ambulate, they may wander or elope. They may have problems sleeping, and language can be affected at this stage. The last stage, stage 7, end-stage severe dementia. This final stage, people will start to lose their complete ability to speak or swallow. They will need extensive help with their ADLs and possibly ambulation. They will have poor muscle control. They will often not recognize family members and will always be disoriented. To get an actual diagnosis of dementia, you need the following: a comprehensive physical exam, a neurological exam, a CT or PET scan of the brain, a psychological exam, and typically those are difficult to get while the person is still alive. So mental status exams can help us give us an idea of the areas of deficits that a person with dementia has. Mental status exams such as the BIMS, the MOCA, the SLUMS, they can all provide information about an individual's capabilities, such as in the areas of problem solving, orientation, recall, memory, or executive function. Module 2, Principles of Person-Centered Care, Assessment, and Care Planning. The development of person-centered care approach is widely attributed to Professor Thomas Kitwood in the late 1980s in the United Kingdom. Person-centered care is a way of providing care to people by focusing on the person's uniqueness and preferences instead of the disease. You must put the person first. It supports positive control and self-direction of the individual. Caregivers work to provide service or aid that occurs as naturally as possible to help a person live a fulfilling life. Other characteristics of person-centered care, or PCC, are looking at behaviors such as communication, upholding values of the person while promoting positive health and finding meaning even with impairments. When I think of providing quality care to someone or improving their quality of life, all of these psychological needs need to be met, such as love, inclusion, attachment, identity, occupation, and comfort. So what does this mean to each person? It means expressing what you want in your everyday life, taking control, maintaining control of your life, making your own choices, connecting and contributing to the community, having opportunities to improve your life, and having family and friend involvement. So what does this mean for providers? The individual is at the center of planning and implementation. We want to try to match staff based on personality and needs to our residents. Staff should know their responsibilities and know when and how to respect privacy. Flexibility should be a main thing with staff, as well as always asking questions such as what's working, what's not working, and what do we still need to learn.
The idea of losing memory is a very scary thing for most people.
Short time. Okay, you can count that one out for yourself. I'll pull him out from this pile here.
Dementia doesn't take away your ability to be a human, your humanness, and it shouldn't take away your humanity. On the contrary, it often brings it out.
I believe that person-centered dementia care adds to the quality of life of an individual and their well-being by helping them find meaning and purpose in life, by respecting their individuality and to foster their sense of self-worth and dignity, and to really build on their strengths rather than focus on what they can't do and on their deficits. Then it really becomes our work as the care partners to help draw them out and to help find those very meaningful interactions or activities that will connect with their identity, their past identity. And every person, regardless if they have dementia or not, wants to feel like they can still contribute to those around them, that they still feel useful, that they still have meaning in their lives. And so it's to help figure out and help connect whatever that is for them and to draw that out in that person.
Oh, that's lovely. Belva Dickman is my mother-in-law.
Can be right in the center.
I've known Belva for over 40 years.
Perfect. Perfect.
She was known as the Rose Lady, and she'd have cut roses from her garden on the table for many of the holidays. She wants to help.
You did good. Oh, Dr. Sheen.
It's a much more enjoyable event for her when she can participate.
We found a beautiful little home specifically for 8 to 10 people with Alzheimer's to have quality of life
So when we moved him there, we wanted him to have something to connect him to his past.
Right.
Because although the short-term memory was gone, we were hoping that the connections to long-term memory would be helpful. So we made this album, specifically, one photograph per page, so it wasn't confusing.
The staff members and the administrator so wanted to understand what Pinky wanted. This says, this book belongs to Pinky. And we took the staff through it because that was personalizing a relationship with
So they know
Pinky.
who he was, and who he is.
And there were so many things that they did along those lines.
Belva is in an assisted living.
Pretty ladies with the blue eyes, how are you doing today?
What's important is that she's treated with respect and given an opportunity to do the things that have been important to her all her life and that she enjoys. And they recognize that.
When it's sunny, we can go out tanning.
Oh, yes.
An example is she loves ice cream and coffee after every meal. They know this now, and they actually offer her ice cream and coffee after lunch and dinner, even though it's never on a menu.
Well, I'll see you in a little bit for dinner, okay?
Okay.
Okay. We'll have plenty of coffee.
You live your life in a continuum. And for most of your life, people honor your choices. No, I don't want to take that promotion, or yes, I want to take that promotion. They honor your choices. My sense is that person-centeredness, it just means this is the same person. At their core, this is the same person. You can't recognize a lot of the things. That's on you. And so you really need to treat them as the same person, but recognize the limitations that this condition has imposed.
So person-centered planning includes all of these areas that we should get to know of the person. So we should know their visions of the future or goals, their personal strengths, their interests, their support system, their family, or social history, as well as housing. Some examples on how to develop person-centered planning would be using all four of these items, such as a relationship circle, looking or examining their daily rituals, good day, bad day worksheet, as well as a 4+1 question diagram. Relationship circles can identify important people in an individual's life and how they can contribute to person-centered plan. Examining the daily rituals of a resident can help create a detailed person-centered plan. The plan can help reveal individualized information for each resident. A good day, bad day worksheet can help you have more better days than bad. It can help identify triggers that can help steer you towards having better days than not. 4+1 question worksheets are what questions that can help provide valuable information about person-centered planning, such as what have we tried, what can we learn, what are we pleased about, and what are we concerned about. How do you know if your plan is working? Well, you must constantly be in a cycle of planning, doing, checking or assessing, and then acting, so that we can catch problems earlier and adjust. With dementia, because the disease is progressive, we always need to be checking our plan, seeing if it still works, and adjusting as time goes on, because the symptoms will change as time goes on with dementia. Personal care that is personalized. Everything should be included, from basic to complex tasks, such as hygiene and beauty. So we must take a look at how a person likes to put their makeup on or style their hair. Or, for example, do they like showers or bath? All of that should be personalized. Meals. Meals should be care planned as well, because often meals can be stressful for persons with dementia. The food may not taste the same, or the preparation can be difficult to handle. Paying special attention to these residents during meals can play a major part in their health. Care planning and assessment. Movement and exercise are very important. You must look for ways to incorporate outdoor time with the residents, such as walking clubs or quiet time in the courtyard or gardening. Exercise can improve overall health and mental well-being for residents. But as with everything, we must take into account each individual needs and preferences. Reminiscing. Because short-term memory is typically affected first with dementias, and long-term memory can remain intact for longer, spending time reminiscing can be very comforting and important. So, looking at old pictures and videos and telling stories from the past can actually help fire up the brain and improve cognitive functioning. You also don't want to provide too much stimulation for residents, because it can be overwhelming to process all of that input. So including time in the day to wind down and relax is often helpful for residents. Residents living with dementia may need some assistance winding down and relaxing on their own. So when aids are identified or tools that can be helpful to calm a resident, then it should be also added to their care plan. One example of this can be handing someone their photo album after lunch as a cue to sit down and relax, or putting on someone's favorite TV show or book. Don't forget about the evening and nights. Evening and nights are so important when you're addressing residents with dementia because of issues such as sundowning or increased confusion during the evening hours that make it difficult for residents to relax. Attempting many different avenues of relief can be helpful in creating a person-centered activity or plan to increase comfort and calm during the evening hours. The time after dinner is a crucial part of a care plan for dementia, because it offers a chance for loved ones to relax and prepare for the next day. Listening to audiobooks, calling or Skyping family members, taking an evening walk, or enjoying the company of friends can help memory care patients wind down after an eventful day. The care plan should address any successful and person-centered activities that create a comfortable and peaceful evening, especially if the person tends to become anxious in the afternoon or evening hours. Module 3, Improved Communication. We'll be discussing communication changes as they relate to dementia, staff communication skills, and how culture and communication relate to one another. So communication changes related to dementia can include all of the following, such as a window of lucidity, which is a moment when a person with Alzheimer's disease or dementia suddenly remembers things and talks clearly. There can be stereotypical language, such as, phrases like, "you got me," or "easier said than done." Those will be easier to retrieve mentally, rather than coming up with a new spontaneous sentences sometimes with people with dementia. There can be empty speech, where language progressively gets worse and nouns become more difficult to retrieve than general terms. So for example, they'll say things like, "put that thing in that thing." And they may have some more difficulty with word finding during conversation. There'll be violations of conversational rule, where a person with dementia are inappropriate, blunt, rude. They may cry during a conversation or swear. You'll see things such as verbal repetitiveness, where they'll repeat things over and over, repeat words or sounds. They'll return to their native language. So if English is, or any language is their second language, they'll typically revert to their native language, which is easier to retrieve cognitively than their second language. Overall, as the dementia progresses, their speech will decline altogether. And they can rely on gestures more than speaking when they have lost the words to communicate. So communication is not just words. There's nonverbal communication as well, such as facial expressions, eye contact, gestures and touch, tone of voice, body language. And this goes for both ways, for staff communicating to residents and residents communicating to staff. So some communication barriers that are created by caregivers are things such as rushing when they're speaking, raising their voice, demanding or commanding a resident, asking memory questions such as, "Don't you remember I told you this? I gave you your medication already." Or things like offering long explanations or arguing. Or this last one, reality orientation versus living their truth. We'll take a closer look at now. So reality orientation versus living their truth. This is where you have a person with dementia who's confused and disoriented, and you attempt to reorient them instead of quote unquote living their truth and providing answers that make sense to the individual. So for example, if a woman is asking for her husband over and over again, and you know that her husband has died over 10 years ago, would you reorient her and tell her, "I'm so sorry, your husband has passed away"? Or would you live her truth and say, "Oh, okay, well, your husband will call a little later," or "We'll go do this activity first and wait for your husband to come and visit"? Something to help calm her down. So when you're thinking about this, I want you to think about some residents thinking that you're lying to them. So if you do want to live their truth, you do want to pay attention to how residents react to those quote unquote living their truth statements, so that you know that that's beneficial for residents, because it may not be sometimes. I know a lot of the times our staff, we try to calm residents by telling them, by living their truth and telling them that, you know, their mother or father will be coming to see them, or whatever delusion that they may have at that point. We kind of play a part in it. But we do want to pay attention to each person as individuals, because dementia can affect individuals all differently. So someone in the earlier stages of dementia may benefit from reality orientation to reorient them, especially if whatever you're orienting them may not cause them sadness or grief, rather than living their truth sometimes, which can cause suspicion and confusion. So you always want to incorporate person-centered planning or care into communication. You want to listen to the words that your staff is using to describe residents. The staff is here to assist residents with dignity. Put the person first and not their characteristics. So don't refer to residents as quote-unquote feeders, or you need to refer to them as someone who needs assistance with feeding. Or when you're putting on clothing protectors during meals, don't refer to them as bibs. We want to give them dignity and respect. So caregivers' general attitude and approach is important. With communication, you should always try to include a smile, being calm and flexible, as well as being non-resistive and guiding, not controlling. Remember, your mood is contagious and attitude is everything. So caregiver verbal reproaches. You want to try to use exact, brief, and positive phrases and repeat as necessary. Speak slowly. Use a warm, genuine, adult tone of voice. Don't use baby talk. Use familiar words to a resident. Give one-step directions slowly at a time. Break down each task. Try to eliminate distractions such as the radio or TV when attempting to communication. And include the patient in your conversation when you can. It can be confusing to a resident if they start to hear you having a conversation in front of them without directly talking to them or addressing them. Some caregiver nonverbal approaches can be approaching from the front and standing or kneeling in front of the resident to maintain eye contact. Make sure you use slow, steady movements, using touch where it's welcome and appropriate, reducing background noise, demonstrating your requests with gestures, praising non-verbally with nods, smiles, or pat on the backs. And when all else fails, just walking away and trying a different approach may be beneficial. The last area of discussion for improved communication is how communication and culture relate. A person's history, language, expressions, social norms, and behaviors are all influenced by culture. We have to become socially competent to provide the best care and work together with staff. Examples of cultural competency are understanding the way a person defines family and or health, understanding how culture impacts individuals' thoughts and actions, understanding how to act during social situations, and understanding what it means to be socially accepted or fit in. The key to culture and understanding each other is to not assume. Don't make assumptions about a person's name or appearance. Don't assume someone speaks English or any other language. Don't assume that the person cannot communicate because they don't speak or read English. It could be a sensory loss. Don't assume someone has certain religious values. Don't assume gestures or tone of voice are meant to be argumentative or aggressive. And don't assume that the way you define relationships are the same way that others define relationships. Instead of assuming, you just want to ask. Ask, what do you prefer? What is important to you? What can I do to make you comfortable? How can I best help you? You want to ask yourself, if this was me, how can I change the situation to make it better for the resident? Overall, these are the communication techniques we just discussed and the things that you should use with our dementia residents. Module 4, ADLs and dementia-related behaviors. Activities of daily living and dementia. We'll be discussing dining and meals, oral care, dressing, and bathing. Dining and appetite. Eating food is much more than a simple nutritional intake. It's a symbol of nurturing. It is involved in many of our happy memories, such as holidays, birthdays, rituals, and special events. Eating is also cultural. It plays a large part in our lives. The loss of appetite due to problems with memory and judgment can cause people with dementia to have difficulty with food. They can also have difficulty because they're not feeling hungry as much as they were before. Possible causes of their poor appetite could be due to food aversions, or portion sizes are different from home, their reduced ability to smell or taste. Depression can be a cause for poor appetite, mouth pain, dental discomfort, hand dexterity problems, difficulty feeding oneself, GI issues, difficulty concentrating or too much noise, or chewing or swallowing difficulty. So interventions for meals, including a large clock in the dining areas, can be helpful for residents. Putting decorations on the walls or tables that help signify meals and eating, such as putting things such as a big fork or a knife on the wall, or pictures of someone eating. Playing light music in the background with no words can help with residents feeling calmer during dining. Using a bread machine or popcorn machine before meals can help increase appetite. Using clear glass containers in the common areas can help encourage drinking, as well as making sure the food is not too hot or too cold. Trying to avoid patterned plates and using plates with contrasting placemats can be helpful for people with sensory issues, as well as consulting an SLP or speech therapist when they see problems with swallowing or chewing. Oral care. Oral care is important with dementia residents because a lot of the times they forget how to brush their teeth or care for their dentures. This can be an issue because with some medication, reducing saliva, this can act as a buffer for tooth decay and gum disease. As well as residents with dementia in the later stages can typically have some oral defensiveness where they will not allow you to help them brush their teeth or put anything in their mouth. This may be difficult for residents. Poor oral care may cause bad breath, cavities, swollen gums, loose teeth, and all those things can further develop into heart disease, stroke, and pneumonia. So some interventions for oral care could be encouraging a resident to brush after meals or at least rinse with low alcohol or diluted mouthwash. You want to pay attention to the timing of oral care. It could be that a resident may not like to brush their teeth early in the morning. It may be later in the day that is a better time to provide oral care. Make sure that the dentures fit correctly. You always want to check the mouth for sores, which can cause pain, and involve the resident as much as possible in the process. Use those communication strategies we just discussed. And as well, for preventative care, schedule dentist appointments regularly. So dressing. The well-being and self-esteem of residents are often linked to personal appearance. A resident's dependence on others may affect their feelings and they may feel like there's an invasion of privacy and personal space when you're trying to dress them. There can also be some difficulties that can arise from a resident having difficulty with mobility, having increased fragility, sensory impairments, and cognitive decline can all impact a caregiver providing aid during dressing. So some interventions for dressing could be sensitive to the resident's feelings and reactions and provide privacy. Assist only when necessary. Provide residents with dementia limited choices to a few favorite items so they have a sense of involvement, but you don't overwhelm them. So instead of showing them their closet and ask them, pick whatever shirt you want to wear today, you give them a choice of 2 shirts and say, which one would you like to wear today? Speak calmly and slowly. Use some more of those communication strategies we just discussed. Break down the task. Residents may have difficulty sequencing the task, and verbalizing the steps can help simplify that. Limit the distractions and noise. Provide consistent staff if possible, and use cues and gestures and gentle reminders when needed. Bathing can be difficult for residents with dementia. Clients may be resisting to bathing because it's no longer pleasurable, uncomfortable, cold, or even painful. The bathing can cause dry skin and itching, and it can be perceived as an invasion of privacy. It's a very private matter to be bathing. We're next going to watch a video on bathing. The caregiver and resident are located in their home. So please take a look at the video and see how you can take some intervention techniques and use them in the long-term care setting.
My mother used to shower every day. Now, if I don't remind her, she refuses to bathe at all. If I try to help her, encourage her to take a bath, she argues with me and gets upset, says she's afraid of the water. What can I do? Mom, it's 8 a.m. Time for your shower.
Oh, I don't need it. I don't want one.
Mom, come on, please. We've gone over this over and over.
No, leave me alone. Don't touch me.
Come on. It's been a week since your last one. You need one. Please, get undressed.
A person with dementia will often refuse, withdraw, or fight during a bath or shower. When you're helping someone to bathe, it's important to be sensitive and tactful and to respect their dignity. Remember, washing is a personal and private activity. Bathing can be scary for patients as dementia progresses.
Okay, Mom, it's noon. It's time for your spa treatment.
Oh, I don't really want to go.
But you love the spa. Makes you feel like a queen. Yeah, and after that, we'll go to your favorite restaurant for lunch.
Well, okay, I guess.
All right, good. Let's go. So first, let's start by unbuttoning your shirt. I'm gonna do the top button, and then can you help?
Okay.
Okay. Good job, Mom. Okay, Mom, I'm gonna put a little water on your toes. No, test it. See if it's okay. How's that feel?
Yeah, it's warm.
Good. Now let's wash down there. Can you do that by yourself?
Yes.
Great. There you go. Okay, we're almost finished. I'm gonna turn the water pressure on low and fill up this cup with some water. I'm gonna stand up. You just sit right here. Okay? Just lean your head back and pour a little bit of water on you. And we're gonna gently massage your hair with your favorite gardenia scented shampoo. How does that feel?
Yeah.
Mm-hmm.
Reassure your loved one that even though bathing is a very personal activity, you're happy to help. Ask how she feels and how she would prefer to do things. Here are some additional tips on how to help your loved one bathe. Be flexible on the time. If your loved one doesn't like to bathe in the morning, try a different time of day. If the word shower or bath causes anxiety, use a different term like spa or get clean. Make the bathroom inviting by using flameless candles, aromatherapy, or soothing music. It's important that your loved one feels safe. Install handrails and use a shower chair. Limit bathing to twice a week and give sponge baths in between. Let her know what you're about to do, one step at a time, and have her help as much as possible. Use a towel to drape over her to provide more privacy. If you don't have one available, consider installing a handheld shower head. Being able to aim the water can be helpful and less stressful.
So as the video points out, some interventions for bathing can be providing alternatives such as a shower, bed bath, sink bath, or sponge bath. Providing for privacy and dignity always. Allowing for increased time if the resident needs. having the water and supplies ready before you go into the shower rooms, and always checking the water temperature. Something to note is that water that's warm or comfortable for yourself may not be the same feeling for the resident. So always try to ask and see if they can participate and put in their own opinion for how they like their water temperature. Try to use towels or blankets over the exposed body parts, and try to wash one part of their body at a time. Dementia-related behaviors. We'll be discussing dementia-related behaviors such as depression, repetitive behaviors, false beliefs, rummaging and hoarding, wandering, aggression, and sleep disturbances. Depression is defined as a mood disorder often associated with symptoms that can interfere with daily activities. Some symptoms include and associated with dementia are loss of pleasure, feelings of sadness, worthlessness or helplessness, decreased interest in self-care or daily life, increased anxieties or thoughts that something bad might happen, loss of appetite or changes in sleep, anger, frequent crying, or thoughts of death. Up to 40% of people with dementias are suffering from depression. So some interventions could be providing medication, improving sleep and stimulating appetite, maintaining a daily routine with the right amount of stimulation, frequent praise, some frequent reminiscing on a person's identity or personal strengths, realistic expectations and setting up successful tasks, regular visits to the beauty shop or barber, and taking them out for exercises or engaging in religious or spiritual activities. Here is another video regarding depression with dementia.
My mother never wants to do anything anymore. She used to be so active and social. Now all she wants to do is lay in bed and do nothing all day. I try to encourage her to do something, but she just refuses. It's very frustrating. Ma, you've been in bed all day. Don't you want to get up and do something?
No, I'm tired.
Come on, Mom. You need to get up, or you'll be awake all night.
You go ahead. I'm fine right here.
Come on, Mom. Just for me, please. You need to get up.
Just leave me be. I'm okay.
Okay, I give up. Do what you want.
Depression and apathy occur in many persons with dementia. Apathy is different from depression. With apathy, a person may experience a lack of motivation, effort, or energy to do everyday tasks. People with apathy no longer have interest in talking with others or participating in activities, or they show a lack of reaction to people or things. People with depression may be sad or tearful, irritable, restless, and have feelings of low self-worth. People with depression may also have sleep problems, loss of energy, and appetite changes.
Mom, your friend Maggie's coming to visit today. Let's have you take a bath so you'll be ready when she comes over.
I'm too tired.
And Maggie really wants to see you. I couldn't say no. She'll stay for a little while. Come on, let's get you up.
Okay.
That's my lady. Hi, Mom. Look who's here.
Oh, hi, Maggie. Good to see you.
Oh, hi, Miss Maggie. How are you?
I'm pretty good.
good. You looking good?
Yep. Let's get to work on this puzzle.
Oh, good.
Look at there.
Oh, my.
If the apathy or depression your loved one is experiencing is significant or is a sudden change from their usual self, talk to their doctor, as there could be another medical cause for their behavior that should be evaluated immediately. Don't let depression drag on. Inquire with their doctor about a need for antidepressant medication. Here are some tips on how to manage apathy and depression. Maintain a regular daily schedule, including plenty of daytime physical activity and restful sleep at night. Involve them in activities such as chores around the house that make them feel useful, or other activities such as visiting with a friend. People with apathy and depression often lack motivation and initiative, so help them get started on a task. Time activities according to your loved one's moods throughout the day. They may be more cooperative and willing to do activities, such as taking a bath, at a certain time of day. Use incentives to gain cooperation, such as going to a favorite restaurant after going to a medical appointment.
Repetitive behaviors can be both repetitive movements and or repetitive vocalizations. Residents can display signs of these behaviors by requesting for the bathroom or meals when the services are not needed. They can be showing signs of repetitive pacing or rummaging, or even repetitive stories of an event that occurred or may not have occurred. Anatomically, repetitive behaviors may be caused by memory loss, because as the damage to the brain progresses, areas of the brain that control language and movement are impacted as well. So residents won't remember or understand that they are demonstrating repetitive behaviors. External causes for repetitive behaviors are, at their root, often signs of stress, pain, thirst, overstimulation or understimulation, or even medication side effects. Finding the root cause and forming your intervention around it will be helpful. Evaluate the resident for any condition that may cause discomfort or pain. Remove the resident from an environment that is too noisy or overstimulating. Provide small group activities. Provide comfort items such as food, drinks, music, soft blankets, or things to hold. Provide one-on-one comforting conversation that reminds residents of the past or familiar situations. And at the end, don't confront or ask the resident to stop their repetitive behavior.
My father used to be so active, and now he just sits in his chair for long periods of time, tapping his hands. It's so annoying. Dad, that tapping, it's irritating. Please stop. Dad, cut it out. Just watch TV quietly, please.
Repetitive behaviors occur in some people with dementia. They may do this because they are not able to remember recent events or actions. They might also fixate and repeat words or gestures to soothe themselves. A repetitive behavior could also be considered as an attempt to communicate an unmet need, anxiety, unspent energy, or physical discomfort. As with problematic behaviors, Try to identify the underlying causes to effectively reduce and manage its occurrence.
Dad, you've been sitting here all day. Let's get you up and go grab a snack. Dad, come keep me company while I work. Have a seat. Here are stacks of magazines for you to work on. And I will put on some music while we work.
Okay.
Once you've identified the underlying causes of a repetitive behavior, you can begin to manage its occurrence. Remember that not all repetitive behaviors are bad, especially if they're not a source of disruption or puts your loved one at risk. Here are some tips on how to manage repetitive behaviors. Search for what might be causing the behavior. Are his basic needs being met? Ensure that your loved one is not hungry, thirsty, in pain, or it needs to use the restroom. The repetitive behavior may be an attempt to communicate his needs or feelings. Do not take aggressive steps to stop the behavior, especially if it's harmless. Do your best to ignore it, but be certain to only ignore the behavior, not your loved one. Place a gentle hand on your loved one's shoulder, arm, or hand to redirect his focus to you and away from the behavior. Provide reassurance and try to include your loved one more in your daily routine. He may simply want to feel engaged and included.
False beliefs or sensory experiences, better known as delusions and hallucinations, are common with dementia. Delusions are false ideas, frequently a misinterpretation of a situation. For example, when a person with dementia believes someone has poisoned their coffee. Hallucinations are false sensory perceptions, where a patient sees, hears, feels, tastes, or smells something that isn't there. Some causes are serious mental or physical illness, medication side effects, dehydration, malnutrition, vision losses or low lighting, misinterpretations of sounds, unfamiliar environments, or past history or past trauma. Interventions include medical or psychiatric evaluations, medication intervention, working with their glasses or hearing aids, make sure that they're working properly, and providing fluids or better nutrition. Try to minimize the changes. Having a set routine and caregiver could be helpful. And tracking the behavior and designing interventions to address the root cause. You also want to validate their feelings and possessions.
My mother's been waking up in the middle of the night and seeing things in her room that aren't actually there. We're both exhausted during the day because we're not getting enough sleep at night. Good night, Mom.
Honey, help me.
What's wrong, Mom?
There's an evil man in the room.
Mom, please. There's nobody here. No one's here. Go back to bed. Come on. Look, there's nobody here. All right? Go back to bed. We've got a big day tomorrow. Come on. Good night, Mom.
A person with dementia may experience hallucinations when the disease affects the regions of the brain that are responsible for interpreting sights and sounds. Hallucinations commonly involve seeing or hearing things that aren't there. They can transform ordinary, everyday experiences into frightening episodes. A good approach to reducing hallucinations is to identify and eliminate the objects or things that trigger them.
Honey, help me.
What's wrong, Mom?
There's an evil man in the room.
Oh, really? Let me take care of it. It's okay. Oh, I see. Okay, come on. Come on, I'll take care of it. Now you stay out here. Now he's gone, okay? I'll sit with you until you go to sleep, okay?
Okay.
You know, Mom, I think we should keep your coat rack outside so you have a place to keep your jackets when you come in.
Oh, okay, dear.
Okay? Okay. Good night.
Remember, patients experiencing hallucinations are having a difficult time interpreting their surroundings. Remain calm, reassuring, and try to identify what may be triggering the hallucinations. If hallucinations persist after trying to eliminate them, be sure to discuss this with their doctor. Here are a few tips on how to reduce hallucinations. Look around and try to see things through her eyes. What might cause her to misinterpret what she sees? Identify potential triggers such as open curtains, shadows, mirrors, or televisions left on. In the bedroom, use a nightlight to create a more peaceful sleeping environment. Always remember to remain calm and reassuring. Do not yell or scold her. Help her back into bed and reassure her that she is safe.
Rummaging or hoarding. Hoarding is the consistent behavior of accumulating and storing objects that the resident perceives as necessary, such as, for example, a resident holding on to food in their purse or sugar packets in their drawer. Rummaging involves the sifting through personal items without intent or purpose. Psychological, medical, or environmental causes of rummaging or hoarding can be due to anxiety disorders, depression, fear of forgetting or losing items, fear of being robbed. Some items are perceived as valuable, even though they may not be. Items can provide security and reminders of the past. They can bring comfort, or they can even represent love or other emotions that the resident can't feel in current personal relationships. Dementia may bring about the inability to organize or understand what to do with these items. So, for interventions, we must try to learn some hiding places of the residents. Treat the resident and their things with respect and dignity. Don't force them to give up the items or stop what they're doing. Don't be judgmental. Involve the resident in the plan, if they can, to remove the items. Simplify the environment and put things away when possible. Don't bring extra items into their room. Attempt to remove items daily instead of all at once. Provide rummaging stations or boxes for storage. Place a sign on areas you don't want the resident to enter or open by using the word no, or employees only, or even out of order. Encourage family and friends not to bring items unless they are taking some items out as well. Exchange a valued item the resident won't let go of for something that they want, such as a cup of tea, small group activity, or even personal clothing item. Try not to argue and keep things simple. Wandering and elopement. Wandering is the inability to recognize familiar places or faces. They move about and become increasingly lost or confused about their location. More than 35,000 critical wandering cases are reported annually. It is projected that for the year 2040, about 500,000 cases will be reported. The average search time is about 9 hours, and when individuals are not found within 24 hours, they have about a 50% chance of survival. Wandering can be caused by a change in schedule or routine, a change in their medication, or change in lighting or environment. Delirium can cause wandering. So interventions that can treat wandering would be addressing the root cause. You don't want to say things like, "You remember who I am," or "You remember this facility." You want to track the time of day, direction, stated intent, or other factors to get a potential root cause and devise a person-centered intervention. You want to try to create or remove stimulation in the environment. Try to engage them in activities. Make sure that the resident have liquid and fluids and snacks. Try to assist them with their toileting or have a toileting schedule. Providing exercise. And making sure their glasses and hearing aids are in a place where they can be found. Using wander guards can be also helpful with residents. And now they have new technology such as GPS trackers, which can be put in soles of your shoes or watches as another safeguard.
My father's been living with me for 2 years. He started wandering in the house, trying to go out the front door, saying he wants to go home. Oh, why is that happening? And I don't know what to do to stop it. Stop, Dad! You can't go out.
I'm gonna go home.
This is your home.
No, I'm going to my house.
This is your home. Stop.
Wandering can occur as dementia progresses. It can be triggered by someone reliving an old memory, not recognizing where they are, or by a feeling of distress. People with dementia have less ability to communicate or explain where they're going or why they want to go somewhere. Wandering can be triggered by seeing things that signal leaving, such as the front door, purses, keys, or coats. If someone is wandering, approach them in a calm and reassuring manner. Ask them where they're going or what they need, and then distract them with a new activity.
Dad, where are you going?
I want to go home.
You are home.
No, I want to go home. The kids need me.
This is your home. See? Here's a family picture. There's me and there's Tom.
But where are the kids?
I'm right here, Dad. I'm your daughter, Jane. And Tom, your son, he just lives 5 minutes away. Let's go give him a call on the phone and say hello.
That sounds nice, honey.
Okay, come on.
Wandering can still happen, even if you're the most diligent of caregivers. Use the following tips to help lower the chances of wandering. Use a calm tone of voice and ask your loved one where he's going or who he's looking for. Reassure him that he's home, point out familiar things around him, and then immediately distract him with a pleasant activity to allow him to forget his urge to wander. Disguise the door by painting it the same color as the wall or covering it with a large poster or picture. Murals for doors can be purchased on the internet. Cover the doorknob with a drape. Try placing a black doormat in front of the door. Some patients will avoid crossing the mat. Put signs on doors to discourage leaving, such as stop signs, do not enter, or keep out. Make sure your loved one is getting enough exercise. The urge to wander could be a result of unspent energy. Ask if he has any needs. He might be wandering because he feels physical discomfort or stress. Be specific. Ask if he would like a sandwich or some coffee, or if he needs to use the bathroom. Do not leave coats, hats, or keys in plain sight or by the front door, as they can trigger the urge to leave.
Aggression is a physical or verbal outburst or socially inappropriate actions or behaviors. Physical and verbal outbursts are often not intentional and have a root cause such as pain, frustration, boredom, loneliness, fear, overstimulation, embarrassment, or history of trauma. Some interventions would be, again, analyzing the root cause. Document details of an event to help with root cause analysis and identifying patterns. Always introduce yourself and explain calmly why you are with the resident and what you're about to do. Walk away if needed and come back later. Try and keep a set routine. Eliminate noise. Eliminate harsh lighting. Eliminate too many people in the room, such as a roommate or other staff if possible. Approach slowly from the side with non-threatening body language. Start with something comforting, such as soft music or greeting or a snack. Offer as many choices as possible. And lastly, don't take any of the behavior personally.
I hired a caregiver to stay with my mom while I'm at work. My mother becomes mean and aggressive towards the caregiver when she tries to get her ready in the morning. Like, mom yells at her to get out and may even try to slap her away. It is a daily struggle, and the caregiver is ready to quit. I can't be with my mom every single minute, and I don't know what to do.
Tina, it's time to wake up. Let's go to the bathroom to clean up. Let's get out of bed.
I don't want to get out of bed. I don't want to get ready.
Come on, not again. Please don't give me a hard time. Your bed is wet. You need to wash up. It's 9 a.m. It's time for your breakfast and medication.
I don't feel like it. I don't need your help.
Stop it and calm down.
Don't touch me. How dare you telling me what to do? I don't need your help.
I am just doing my job. Let's get ready for the day.
I don't need you. Get out of my house and leave me alone.
People can become aggressive for many reasons. It may be an expression of pain, fear, frustration, depression, or anger. People with dementia may not understand what you're asking them to do and become frustrated. They may genuinely not understand what they need to do something, like take a pill or bathe. Aggression usually isn't personal, although it certainly feels that way. Reacting to aggression with anger, shock, or yelling only escalates the situation. First, de-escalate the situation by behaving calmly. Identify yourself if you need to. It's possible that your loved one does not recognize you. Speak to the emotions that might underlie the aggression. It could be fear, pain, or frustration. Use distraction, encouragement, reassurance, and try to be flexible if someone is being uncooperative and angry.
Good morning, Tina. This is Jane, your caregiver. Your breakfast is ready. Would you like to eat downstairs?
I like my bed. I want to stay here. You can bring my breakfast here in bed.
I can do that. I see that your bed is wet, though. I would like to make your bed so you can rest comfortably. Meanwhile, would you like to eat at the dining table?
No. I want to have my food here in bed.
Okay. How about if you eat right over here, just while I make your bed?
Okay. Fine.
Here are a few tips on how to respond to aggressive language and behavior. Keep it simple, one instruction or question at a time. Don't escalate tensions by being bossy or yelling. Instead, use a calming tone of voice, but do not be condescending. Provide reassurance. Let your loved one know you're there for support. Keep your body language positive and use calming gestures and gentle touch. Give ample time. Redirect or give ample time and space for cooling off and reattempt later. Remain safe. Back away slowly if the behavior is threatening. Remove or lock away all weapons like guns and knives. Call 911 if physical aggression cannot be redirected and your loved one is a danger to themselves and/or others.
Sleep disturbances are sleep patterns which can be sleeping too much or too little or sleeping at inappropriate times. And they can be disrupted due to physical inactivity, overstimulation before bed, pain, medication, depression, poor prior lifestyle, change in environment, or environmental stimulation such as noise or lighting. Interventions may include considering medication side effects or medication adjustments, providing exercise during the day, turn off the hallway light or cutting down on the hallway noise, providing activities at night if this was part of the past lifestyle, providing snacks and don't have caffeine or offer sugar at night, and always assessing for pain and treating pain.
My mother sleeps all day and keeps everyone awake at night. In the morning, we tell her to get up and do something, but all she wants to do is sleep. When nighttime comes, she's awake and keeps the whole house up. How are we supposed to get any rest? Go to sleep, Mom. Everyone else is sleeping. What are you doing awake?
I need to get ready for work. I don't want to be late.
What are you talking about? It's 2 a.m. You haven't worked in 20 years. Please, just go to sleep. I have to wake up for work in a few hours.
You don't know what you're talking about. You're just a kid. Now, you go back to sleep, and I'll wake you up when it's time for your school.
School. Please, just go to sleep. Would you just stop bothering everyone?
Who am I bothering?
I'm going back to sleep.
Sleep disturbance is a common problem in dementia. Some patients may mistake daytime for the nighttime, while some sleep excessively in the morning and stay awake at night. They may wake up in the middle of the night confused and disoriented. This presents safety issues such as falling, wandering, and other unsupervised behaviors. For some patients, sleep disturbance is caused by or made worse by excessive napping, lack of daytime activities, and not enough exposure to sunlight. Medication effects, caffeine, alcohol, and pain can disrupt sleep-wake cycles. In any event, if your loved one is awake at night, stay calm and be patient. Keep in mind that how you respond to the situation greatly affects the outcome for your loved one.
What are you doing up, Mom? Do you need some help?
Oh, no, I need to get ready for work. I don't want to be late.
Hey, Mom, it's actually 2 in the morning, see? Everyone else is sleeping. It's not time for work yet.
Oh, but wait, what are you doing up there? You should go back to sleep. You have school in a few hours.
You're right. What would you say to a glass of warm milk? One for you and one for me. And then we'll both go back to sleep.
Sounds like a good idea. Oh, but we can't stay up too late.
I agree. Let's go to the kitchen for that milk then. You can help me warm it up.
Oh, good.
Here are some tips to help minimize sleep disturbances and increase the chances of restful sleep. Maintain a regular schedule for meals, bedtime, and getting up in the morning. Seek morning sunlight exposure, but eliminate light from computers or bright lights 90 minutes before bed. Encourage daytime exercise several times a week, but avoid vigorous physical activity a few hours before bedtime. Limit naps to once a day, if at all, and no longer than 30 minutes. Keep the person busy during the day. Going to an adult day facility or having a friend or relative spend time with their loved one will help keep them awake and stimulated. Avoid alcohol, caffeine, and nicotine, which can interfere with falling or staying asleep. Avoid over-the-counter PM medications. Provide adequate pain management if appropriate. Provide nightlights and fill the bedroom with familiar objects like family pictures to reduce disorientation in case the person wakes up during the night. If your loved one awakens, discourage them from staying in bed while awake. Use the bed only for sleep and instead encourage them to move to a bedside chair and listen to relaxing music while keeping lighting dim and the room cool.
So in review, the overview of strategies for managing behavior, all behaviors, can be to anticipate problems or events, provide a routine, establishing a rapport, talking in a calm voice. Do not try to attempt to reason or logic with residents. Do not rush. Avoid arguing. Focus on residents' abilities. When you approach residents, you always want to knock, announce, and always maintain their privacy. Encourage the person to do as much as they can. Praise the resident for small successes. Maintain that privacy and try not to keep the resident waiting on you. Demonstrate what you've done and always try to stop frustration when it's occurring. Thank you for attending our Alzheimer's disease and dementia care training for 2022. Please take your general module quiz at this point.